Hey, welcome back to the Critical Care Shock Lecture Series. We're back this time talking about distributive shock. At this point, it's worth mentioning that distributive shock is the most common class of shock among ICU patients. This makes it an especially important lecture, a lecture that we're going to take a deep dive into the etiologies of distributive shock. As most of you likely already know, my name is Bob Gibson. I'm an acute care nurse practitioner. I have no relationship with industry or any financial disclosures to report. I am the president of ROSC LLC, a critical care education company. We've already thoroughly discussed the diagnosis and terminology of shock in previous lectures. So today, we're going to get right to the point and discuss specifically about distributive shock. We'll discuss the hemodynamic profile of distributive shock. We're going to cover septic shock, non-infective inflammatory shock, anaphylactic shock, and neurogenic shock. And while there's a few pathogenic endocrine-driven processes worth mentioning, I feel you'll be most exposed to adrenal insufficiency, so that's what we're going to discuss in this lecture. I have separate videos on the more rare, sexier diseases like myxedema coma and thyroid storm. We'll cover post-cardotomy vasoplegia, decompensated cirrhosis, and lastly, we'll have a brief chat on examples of how some medications can put us into a vasodilatory distributive shock. Distributive shock generally has a hyperdynamic profile. Hyperdynamic meaning an elevated cardiac output. And these patients also have a low SVR state, systemic vascular resistance, meaning they're vasodilated. Generally, these patients are tachycardic. And this is a result of the hypermetabolic state and neurohormonal activation. And in addition, we should see tachycardia as a compensatory measure in distributive shock as well. Now remember, this tachycardic process can be blunted if the patient's on any AV nodal blocking agents. There's a few hemodynamic profile variants that I want to point out here. So septic shock is generally a high cardiac output, low SVR state. However, there's a subgroup of patients that might demonstrate a hypodynamic profile as well. While there's multiple causes of this, the biggest culprit would be septic cardiomyopathy. Neurogenic shock, again, is a hyperdynamic process, but due to bradycardia in some patients, this may reduce the cardiac output as well. And then adrenal shock, decompensated cirrhosis, and anaphylactic shock can have normal to high cardiac outputs. The diagnosis within distributive shock classification either have low or normal filling pressures. Filling pressures being your CVP or your pulmonary occlusion pressure. And while these are static hemodynamics, we utilize them at least in the initial diagnosis and attempts at shock classification itself. We also need to be reminded that many patients have a combination of more than one form of shock, right? For example, many septic patients have a degree of hypovolemia as well. And not only could the patient be down on fluid, but they'll generally be at a relative volume deficit compared to the degree of vasoplegia they're at. Here you have a conceptual image of a normal, healthy person's vasomotor tone. Now, this is the same patient's vasomotor tone after they had an anaphylactic reaction. They're dilated out. Now, imagine that normal vessel to the left as a static volume cylinder. Now, let's overlap that dilated vessel. It gives you a great idea of the lack of volume in comparison to the vessel dilation. Now, this is a conceptual example, right? What really happens, we've already discussed numerous times in previous lectures, the blood volume goes from stress volume to unstressed volume, mean systemic filling pressure drops, venous return drops, as well as cardiac output. In part 1 of the shock lecture series, we discussed vital signs and clinical exam in great detail. So with that, I'm going to be quick and highlight some significant findings specific to distributive shock. First up is vital signs. In addition to monitoring your mean arterial pressure and your shock index, we also have some other clues to help us diagnose and manage the patient with distributive shock. Pulse pressure is a valuable tool, and as we know, pulse pressure is equal to systolic blood pressure minus diastolic blood pressure, and normal is 40. Anything less than that is a narrow pulse pressure, and anything greater than that is a wide pulse pressure. And we need to remember that chronic processes like aortic regurg or stenosis or atherosclerotic changes can widen our pulse pressure with age. What we're looking for is an acute change in pulse pressure. Now, for accuracy's sakes, I'll tell you that some references tell you to look at the percentage difference to find the pulse pressure. However, when it comes to shock, it's very difficult to utilize it this way. So to conclude this matter, we'll see a patient in shock with a wide pulse pressure in the absence of aortic disease. We want to think vasodilatation, low SVR. Diastolic blood pressure is a moderately useful tool and indicator for vasodilatation. Traditionally, an acute change in blood pressure demonstrated by a diastolic blood pressure less than 50 or 60 is low. If it doesn't respond or improve to fluid resuscitation, it's an indicator of vasodilatation. Interestingly, less than or equal to a diastolic blood pressure of 40 to 50 is associated with the signal for increased mortality in septic shock. Speaking of predicting mortality with the diastolic blood pressure, there's some building literature telling us not only to look at the diastolic blood pressure alone, but to also include the heart rate into the assessment. And this is referred to the diastolic shock index. And the index test seems to be in its infancy, but so far it appears that if the diastolic shock index is greater than 2.2, it's associated with an increase in mortality. So the diastolic shock index can be obtained by looking at the heart rate divided by the diastolic blood pressure. A diastolic blood pressure less than or equal to 40 with a heart rate greater than 100 may be associated with increased risk of death. When it comes to your bedside assessment, I want to take a moment to recap some vital information. Your job at the bedside is assess for microcirculatory alterations helping you to diagnose shock. Remember, cardiogenic shock patients may appear paler, cyanotic, feel cool, clammy, and have a weak pulse, and this is because they have a low cardiac output, high SVR state. Conversely, distributive shock is characterized by a high cardiac output and a low SVR state, so these patients may be flush, sweaty, hot to touch, and have pounding pulses. So let's get started with the good stuff. First up is sepsis. And sepsis up first because it's the most common cause of distributive shock seen in ICUs. Unfortunately, it's the leading cause of non-cardiac death in ICUs throughout the US as well. So wrapping that package a different way, distributive is the most common class of shock, while septic shock is the most common etiology of distributive shock. Septic shock has very complex pathophysiology. There's books written about it, literally whole books. So with that, I'm just hitting the bullet points here. It's characterized by a dysregulated host response to infection. Infective toxins and factors are triggered. This triggers a humoral response, triggering pro-inflammatory cytokine release. This leads to the release of vasodilatory substances like nitric oxide and prostaglandins. And on top of that, the WBCs adhere to the subendothelium, causing increased capillary permeability, i.e. capillary leak. So overall, sepsis is a vasodilatory state, but in addition, its increased capillary permeability causes intravascular leak. Now let's talk about the treatment of septic shock. We're just going to hit the big points here since we have a whole other lecture on the Surviving Sepsis campaign. First up is early recognition. So early recognition of sepsis is paramount to treatment. We need to treat sepsis and septic shock as medical emergencies. This includes a good H&P, some solid clinical assessment, and the concurrent use of laboratory findings, diagnostic imaging, and screening tools to secure a diagnosis. Next up is early antibiotics and source control. If I had one item in this list to be executed perfectly every time, I would pick early antibiotics and source control. These are the most important items in the sepsis bundle. This includes the administration of antibiotics within 1 hour, not using procalcitonin to tell you to start antibiotics, and then particular attention to high-risk patients for MRSA, multi-drug resistant pathogens, and fungal infections. And lastly, as I've already stressed, this includes emergent source control, and this also includes removal of any potentially seeded or infected devices. Next is fluid resuscitation. This includes a handful of items seen here. 30 mLs per kilo of crystalloid bolus within 3 hours of diagnosis of sepsis-induced hypotension and/or shock, using balanced crystalloids as opposed to chloride-rich solutions like normal saline, dynamic fluid responsiveness testing as opposed to physical exam or static hemodynamic parameters alone, trending lactic acid levels, and cap refill assessment to assist in determining your resuscitation status. And then lastly, the judicious administration of albumin in select patients. We defend a MAP of 65, mean arterial pressure of 65, and guidelines support early administration of vasopressors. Vasopressor support shouldn't be delayed for essential line. In fact, vasopressors via a peripheral IV is initially recommended. The first-line vasoactive medication is norepinephrine, followed by the co-administration of vasopressin at a dose of 0.03 units per minute. There's more clear recommendations in the guidelines now as to when to start vasopressin, and it's when the norepinephrine dose is somewhere around 0.25 to 0.5 mics per kilo per minute. Personally, this recommendation has led me to starting vasopressin much sooner, usually when the norepinephrine dose is 0.25 to 0.3 units per kilo. Then the third tier vasoactive therapy is epinephrine. Then last but certainly not least is stress dose steroids during septic shock. The guidelines tell us that for adults with septic shock and an ongoing requirement for vasopressor therapy, we suggest IV corticosteroids. So what does that really mean though? So it means that your patient's on norepinephrine or epi at a dose of greater than 0.25 mics per kilo per minute for at least 4 hours. And I think this is a valid discussion point. I see sometimes people throwing the kitchen sink at patients. Fluids, pressors, steroids all at once. The guidelines building in a 4-hour wait time in order for you to optimize fluids and vasoactive administration. We talk more about this during the septic shock lecture, but for now, know that we use hydrocortisone at a dose of 50 milligrams IV every 6 hours. Next, we have non-infective inflammatory shock. This is organ dysfunction or a shock related to an ischemic or inflammatory process rather than an infectious etiology. Now, the pathophysiology of inflammatory shock is similar and just as complex as sepsis. In fact, it often mimics sepsis. It includes an exaggerated humoral and cellular response, complement activation, and pro-inflammatory cytokine release. And as one would suspect, as a generalization, this similar response yields a similar hemodynamic profile of a hyperdynamic vasodilatory shock. We see this with polytrauma and burns. We see this with pulmonary aspiration. It's historically referred to as Mendelssohn syndrome. We all should know that this is a common presentation for our severe pancreatitis patients. And then lastly, we see this profile with post-ischemic reperfusion. So we might see it with our acute MIs. We might also see it with our post-resuscitation from cardiac arrest. And technically, vasoplegic syndrome that we see from on-pump CT surgery patients and even ECMO patients fit into this category, but I want to have a separate discussion on this towards the end of the presentation. As far as treatment, I don't have landslide recommendations here. Supportive care should focus on treating and resolving the underlying trigger. We should focus on appropriate fluid resuscitation. And then lastly, we should be reaching for our vasoactive medications to support our SVR and our mean arterial pressure. And there's not clear recommendations in this department, but one would surmise that norepinephrine is the suitable first-line agent. Next, we have anaphylactic shock. The World Allergy Organization defines anaphylaxis as a serious systemic hypersensitivity reaction that usually is rapid in onset and may cause death. So severe anaphylaxis is characterized by potentially life-threatening compromise in the airway, breathing, and or the circulation. And we all know the common symptoms here: shortness of breath, wheezing, stridor, hypotension, tachycardia, and edema. The most feared form of edema is any that might compromise the airway. Other symptoms include cutaneous findings like itching, flushing, or hives, and while most cases have cutaneous findings, not all of them do. Some patients might even experience GI symptoms, including abdominal cramping, pain, and nausea and vomiting. It's apparently an often unrecognized process. I think the better way to say this is that it's recognized too late. Early recognition, diagnosis, and administration of epinephrine is vital to the survival of patients with anaphylactic shock. Most reactions are uniphasic, but some are biphasic, meaning the symptoms may return within an hour or two with biphasic reactions. Looking at the pathophysiology briefly, a trigger or an allergen is introduced. This could be anything from a food, a medicine, an environmental exposure, or even an envenomation. And sometimes, unfortunately, it can be idiopathic. Regardless, this spurs a predominant IgE-mediated hypersensitivity response. So in simpler wording, an antigen presents itself to an antibody. This activates basophils, mast cells, and sometimes eosinophils. And if you recall from bio class, mast cells and basophils are packed with preformed granules that contain histamine or tumor necrosis factor, prostaglandins, or leukotrienes. In regard to shock, histamine causes vasodilatation and tachycardia. Leukotrienes and prostaglandins cause bronchospasm and increased vascular permeability. And prostaglandins, unfortunately, attract more eosinophils, more basophils, and more mast cells, so it's a cyclical process. Here's a nice depiction from the National Institute of Allergy and Infectious Disease. The graphic shows us diagnostic criteria for anaphylaxis. It revolves around respiratory symptoms, blood pressure findings, mucocutaneous symptoms, as well as GI symptoms. Scenario 1 includes a sudden onset of hives or edema with at least one of the following: sudden respiratory symptoms or hemodynamic changes. Scenario 2 includes 2 or more of the following symptoms after exposure to a likely allergen, meaning I don't think I am allergic to a bee, but I just got stung by a bee. We look for mucocutaneous symptoms, respiratory symptoms, hemodynamic changes, or GI symptoms, and remember, you only need 2 of these symptom classes to qualify. Then we have scenario 3. This is any hemodynamic change after exposure to a known allergen. An example here would be that I know I'm allergic to bees and I just got stung. Then my blood pressure drops. So that would meet criteria that way. As far as treating anaphylactic shock, how do we go about that? We obviously want to remove the inciting trigger, if it's even been identified. After that, epinephrine is the cornerstone of management. No other medication should even be thought about until sufficient epinephrine administration is underway. No other medication has been found to be as effective. This starts with IM administration of 0.5 milligrams for an adult using the 1 milligram per ml dilution. Now, back in the day, we referred to this as 1 in 1,000 epi. This has gotten confusing though and has led to medication errors, and for that reason, we should focus on the milligram per ml dilution. If needed, you can repeat this dosing every 5 to 15 minutes. Now, if you don't see improvement, or worse yet, the patient's decompensating further, you can start an epinephrine infusion starting at a dose of 0.1 mics per kilo per minute. Now, airway assessment and management is of utmost importance when dealing with anaphylactic shock. So intubation should be performed immediately for any stridor or respiratory distress. Early intubation should be considered for any significant edema of the tongue or oropharyngeal tissues. Now think about it. It's better to intubate early than to have to perform an emergent surgical airway later. We should provide appropriate fluid resuscitation as discussed in previous content due to central functional hypovolemia. As far as adjunctive therapies, these therapies have not been proven to be overly effective for the acute management and should not delay the administration of epinephrine. The last thing we want to do is these adjunctive medications to distract us from giving epi. We can consider the histamine blockade. This is a combination administration of H1 and H2 blocker. This is more effective for cutaneous symptom management and really does nothing from the cardiopulmonary standpoint. Lastly, corticosteroids. They've been debated for decades. First, steroids take up to 6 hours to exert their anti-inflammatory effect. So if they're going to do anything, they're not going to benefit your patient up front. It seems like its historic use was in hopes of preventing a biphasic reaction, but literature isn't supporting that currently. Now, in a patient as sick as ours in the ICU, in shock and bronchospasm, we're most likely going to reach for IV corticosteroids to help with airway edema, bronchospasm, and maybe even vasomotor tone. As far as what steroid, we don't know. Methylprednisone, hydrocortisone are probably smart choices depending on the situation. Lastly, bronchodilators. Again, don't let them delay your administration of IM epinephrine. Epinephrine is the most important treatment for anaphylactic shock. Now we're going to briefly cover neurogenic shock. The main cause of neurogenic shock is spinal cord injury. However, TBI, spinal anesthesia, and non-traumatic myopathies can also cause neurogenic shock. But for most of us, if we're going to see this type of shock, it's going to be secondary to a spinal cord injury. Mechanisms of injury can range from diving accidents, falls, blunt and penetrating trauma, and even sports-related injuries. It's interesting, only about 20-30% of patients that have a high cervical injury experience neurogenic shock. And this is thought to be due to the various severities and degree of the cervical injuries, i.e. incomplete versus complete lesion injuries. Now, neurogenic shock carries some very interesting pathophysiology with it. Varying degrees of neurogenic shock can be seen when there's a spinal cord injury above T6. I don't want to make this an in-depth neuro lecture, so to keep it brief, we generally see more severe neurogenic shock as the lesion injury moves cephalad. In addition, the more severe or complete the injury, the more severe the shock. And generally, bradycardia is more common in high cervical injuries. Here you have a patient with a severe injury to C4. You can see the spinal cord is compressed and it's pinched, always remembering there's a primary and secondary injury when it comes to the spinal cord. This patient's more prone for full-out neurogenic shock. This injury causes a disruption in the sympathetic nervous system. More accurately said, a disruption in the descending sympathetic tracts. The parasympathetic system's still preserved, so there's unopposed parasympathetic stimulation. This results in vasodilatation and bradycardia. Before moving forward with treatment, I want to take the time to step back for a second. Since a lot of these spinal cord injuries are traumas, we want to rule out hemorrhage. Normal heart rates and bradycardia in the light of shock normally doesn't push us towards hypovolemic shock. But remember, there's exceptions where you might not see a compensatory tachycardia in hypovolemic shock, like in young athletes or patients on AV nodal blockers or neurogenic shock. So neurogenic shock should be diagnosed by exclusion. Now back to treatment. When it comes to airway, for obvious neurogenic reasons, depending on the site lesion of injury, breathing may be anywhere from impaired to absent, so early intubation is key, and be sure to respect C-spine immobilization. Appropriate fluid resuscitation is next, and if the patient's refractory to the fluids, then we need to work on the heart rate and blood pressure. Now, in real life, all these things are being employed in concert usually. Since this is unopposed parasympathetic action, we can try latropine. From there, we can focus on vasoactive therapy. There's no clear recommendation or consensus on the preferred agent, and honestly, I feel it's because there's variability in presentations and severity. Traditionally, phenylephrine was utilized in the absence of bradycardia, and I'm sure that was fine, but newer recommendations are pushing towards an agent with alpha and beta stimulation. Regardless if your patient's bradycardic or has borderline bradycardia, the better option may be norepinephrine, dopamine, or even epinephrine. Now, defending MAP is always important in shock, but it's even more important here because hyperperfusion equates to worsening spinal cord perfusion and worsening outcomes. In fact, while the current recommendations are a bit fuzzy, most clinicians opt to drive the MAP to 85 in acute spinal cord injury patients. Now we're going to take a deep dive into adrenal insufficiency. So this is the hypothalamic pituitary adrenal axis. It consists of the hypothalamus, the pituitary, and the adrenal glands. So it works together to regulate things like blood sugar, protein fat metabolism, memory regulation, and anti-inflammatory or stress modulation. So in fact, think of this axis superficially as a stress response system. When your body needs glucocorticoids, the hypothalamus releases corticotropin-releasing hormone. And this stimulates the pituitary to release adrenal corticotropin hormone. And this triggers the adrenal glands to secrete cortisol. And remember, we have a negative feedback to the system. As cortisol levels get high, CRH and ACTH drop, and this causes the cortisol levels to normalize. In the realm of adrenal insufficiency, there's three main types. Primary adrenal insufficiency involves just the adrenals. This results usually in both a glucocorticoid and a mineralocorticoid deficiency. The most common cause of primary adrenal insufficiency is autoimmune disease. Other less common causes range from infection, trauma, hemorrhage, infarction, metastatic disease, medications like fluconazole or ketoconazole. The most common critical care medication that passes through my hand in this situation is etomidate. It suppresses 11-beta hydroxylase, which is key in the final metabolism of both glucocorticoids and aldosterone. So said more simply, a single bolus of etomidate can suppress cortisol and aldosterone for up to 24 hours. Secondary adrenal insufficiency involves just the pituitary, and tertiary adrenal insufficiency involves the hypothalamus. So secondary and tertiary adrenal insufficiency are commonly referred to as central adrenal insufficiency. Central adrenal insufficiency results in a predominant glucocorticoid deficiency. There's numerous causes of central AI ranging from pan-hypopit syndrome, autoimmune issues, genetic issues, malignant issues, radiation, infection, traumatic brain injuries, and again, even medications. Something that's interesting to mention, prolonged use of opiates can also contribute to low plasma ACTH levels. We all remember that the adrenal glands essentially have two separate units, right? The medulla, which produces catecholamines and certain peptides. Then we have the outer layers referred to as the cortex. And within the cortex, there's three layers. The zona glomerulosa, which is responsible for releasing aldosterone. The zona fasciculata, which is responsible for secreting cortisol. And then lastly, we have the zona reticularis, which is responsible for secreting androgens like estrogen or testosterone. And if we think about it, glucocorticoids are regulated by these tropic hormones, CRH and ACTH. These tropic hormones signal the zona fasciculata to release cortisol. Conversely, mineralocorticoid regulation isn't dependent on these tropic hormones, and that's an important point. Its main regulation is in concert with the RAS system. The kidney sense a state of hypotension and hyperperfusion. They release renin. Renin causes angiotensin to be released from the liver. This causes angiotensin 1 production. Angiotensin 1 is hydrolyzed to angiotensin 2, and then angiotensin 2 stimulates the zona glomerulosa in the adrenal gland to produce aldosterone. When it comes down to critical care and shock, technically insufficiency in glucocorticoid and mineralocorticoid can cause hypotension and shock, with the tendencies of mineralocorticoid to be more severe. So to recap here, glucocorticoid deficiency can contribute to hypotension by causing reduced response to angiotensin 2 and norepinephrine. It can decrease the synthesis of renin and increase prostacyclin production. Mineralocorticoid deficiency, on the other hand, has a more direct result on shock and hypotension, since it causes a failure of sodium and water retention, as well as a loss of vasomotor tone. If we look at some common lab findings of each, we would see that central AI results in low ACTH, low cortisol, possibly other endocrine disorders because it's central, and then the sodium and potassium would be normal. And if that doesn't make sense of why I'm pointing it out, it will in just 1 minute. Whereas primary AI will have low cortisol, low aldosterone, high renin, high ACTH, and then the sodium will be low and potassium will be high, and this is due to the deficiency of aldosterone. I feel you'll see the three following variants most commonly in critical care. First, a full-out adrenal crisis. So maybe this is a new diagnosis. Whatever the etiology, they're suffering a multitude of symptoms, and if they're meeting ICU admission criteria, they're probably hypotensive. Or this could be a patient with pre-existing chronic adrenal insufficiency that's now stressed from, say, a UTI. For whatever reason, primary or central adrenal insufficiency, they can't mount the stress response needed, and in turn, they become symptomatic and hypotensive. Next, we have iatrogenic adrenal suppression. And I'm calling it this during this presentation to try to present some clarity, but for all intents and purposes, this is technically a form of central adrenal insufficiency. This is a patient on chronic steroids that abruptly stopped taking them, or maybe we unintentionally didn't continue the steroids during the mission. This can happen. Or maybe the chronic steroids are being taken, but because of a stressful state, say that they're in sepsis, they're not able to mount an appropriate stress response. And this occurs because the chronic steroids activated the negative feedback loop, preventing CRH and or ACTH release. This hypothalamus pituitary axis suppression can take days to up to a year in some cases to fully recover. Then we have relative adrenal insufficiency. The cool, more up-to-date term is CIRCA, or critical illness-related corticosteroid insufficiency, and our understanding of the disorder is evolving. So what's CIRCA? We used to say that the body was so stressed over, say, sepsis or pain, fever, or surgery that it essentially exhausted their adrenals, causing a shortage or a deficit of the hormones, so they would essentially have relatively low levels of these compounds in comparison to the levels of stress. This doesn't seem to be the case anymore. There seems to be at least 3 major factors at play. 1, the HPA access becomes impaired due to hyperperfusion and shock and the high levels of cytokines. 2, there seems to be impaired cortisol metabolism in the kidney and the liver. And lastly, number 3, there's impaired cortisol to tissue binding due to low levels of carrier proteins and binding globulins. And what does get to the cell and tissue, there also seems to be issues with the glucocorticoid receptor with translocation and transcription at the cellular level itself. So now there's high levels of cortisol circulating that the tissues and the cells can't fully utilize, and to make things worse, the hypothalamus and pituitary are going into negative feedback over the high levels of unusable cortisol circulating in the body. This all equates to a disaster in terms of adrenal insufficiency. Now let's talk about diagnosis. Well, in the ICU, it's tough. It's highly debated, and most would say that ACTH and cortisol diurnal variations are altered during critical illness, making it even more difficult. Some commonly ordered tests can be seen here. The general recommendation is to perform these tests in the morning between 6 a.m. and 9 a.m. However, this is based on the understanding that there's diurnal variation in ACTH and cortisol, and that's dependent on the circadian rhythm. With that, many experts and resources agree that this diurnal variation is disrupted during critical illness and or major surgery. For that reason, you might see folks ordering either in the AM or upon presentation to the ICU, and I find this situation has something to do with the severity of the situation. Since there seems to be so much confusion and error with doing an ACTH stim test, I'd like to review it briefly here. So first, you're going to obtain a random baseline cortisol level. You don't have to wait for the results to come back, but as soon as you draw that blood, you're then going to administer 250 micrograms of concentropin IV push. This is essentially synthetic ACTH. From there, 30 minutes post-administration, you're going to draw a random cortisol level, and then again at 60 minutes post-administration, another random cortisol. Some folks exclude that post 30-minute draw, but I just want to include it for thoroughness. And then the way that we interpret that test is important, and there's really 2 different ways depending on the situation. 1, if you don't have a peak response to the stimulation test of at least 18, you may be adrenal insufficient. And lastly, if you don't have a delta, a change from baseline to post of at least 10, you may be adrenal insufficient as well. Also worth mentioning is doing a random spot cortisol level to try to confirm CIRCA. Now, the SCCM CIRCA guidelines make no recommendations regarding an ACTH test versus a random cortisol test. There's many shortcomings and limited utility in doing a random cortisol, but if you choose to do so, a patient with a random cortisol level of less than 10 to 15 micrograms per deciliter increases the likelihood of adrenal insufficiency. All right, the last few slides have been some pretty complicated stuff, but good news is that treating, at least in the ICU when somebody's in shock, is easy. It's hydrocortisone, 50 milligrams, IV push every 6 hours. If you're searching for true adrenal insufficiency, it would behoove you and the patient to spend the time doing the workup before starting the hydrocortisone. Conversely, if you're dealing with a person with possible CIRCA, the recommendations are to bypass the workup and to just treat it. So if you have a septic shock patient that you have fluid resuscitated and they're on greater than 0.25 mics per kilo per minute of either norepi or epi for 4 hours, it's recommended just to start stress dose steroids. And we'll discuss the literature on stress dose steroids and septic shock in detail during our septic shock lecture next. Now we're on to vasoplegic syndrome. And vasoplegic syndrome is technically an inflammatory cause of distributive shock, but since it has its own unique etiology, I want to discuss it in a separate subgroup here. So vasoplegic syndrome is defined as vasodilatory shock following cardiopulmonary bypass or ECMO, extracorporeal membrane oxygenation. It's a shock that occurs within 24 hours of these technologies. And as far as hemodynamics, it's defined by a cardiac index greater than 2.2 and an SVR less than 800. The inflammatory cascade is triggered by the contact of the blood to a foreign surface. In this case, it's the cardiopulmonary bypass or ECMO circuit. And this can provoke a process similar to sepsis with pro-inflammatory cytokine release and nitric oxide production. And you'll notice treatment's similar to sepsis with a bit of a surgical/cardiac anesthesia spin. So first, we always want to provide appropriate fluid resuscitation. And then in these patients, we want to correct acid-base disorders. Then we're going to turn to our vasoactive medications, primarily norepinephrine and vasopressin. So overall, if you're heading to higher doses of norepinephrine, say 0.2 mics per kilo per minute, you should start entertaining starting concurrent vasopressin. I personally wouldn't go beyond 0.6 units a minute of vasopressin, but some experts advocate for doses up to 0.1 units a minute. Just remember, the higher the dose, the more risk for digit and gut ischemia. And then you can entertain stress dose steroids. And this is an item you definitely want to discuss with your surgeon before starting, weighing the risk and benefits of hyperglycemia, impaired wound healing, and possibly increased risk for surgical site infections. From there, if your norepinephrine is greater than 0.2 mics per kilo per minute and your vasopressin is in excess of 0.6 units a minute, you can consider methylene blue. So methylene blue was historically used to treat methemoglobinemia. However, it's utilized in some forms of vasodilatory shock due to its apparent ability to inhibit nitric oxide production, in turn increasing vascular smooth muscle tone. I have a separate short video on methylene blue, so for now we're just going to keep it moving forward. And from there, if you still have a patient that's refractory from catecholamines, vasopressin, steroids, and methylene blue, you can trial angiotensin too. All right, moving on to decompensated cirrhosis. As we all know, the cardiovascular system in patients with cirrhosis and portal hypertension is very abnormal. Typically, they exhibit a hyperdynamic, low SVR state with borderline baseline blood pressures. We often see these patients in the ICU once they've decompensated. Examples of decompensated cirrhosis is hypotension, ascites, hepatic encephalopathy, and portal hypertension-related GI bleeding. Just a quick reminder on the physiology and the pathophysiology here. The liver receives its blood flow from the hepatic artery and portal veins. The hepatic artery obviously supplies oxygenated blood. The portal vein brings nutrient-rich blood from the GI tract and the spleen for the liver to detoxify and metabolize. Blood then exits the liver via the hepatic vein and subsequently dumps blood from the venous system by means of the IVC. Now, this process is altered in the setting of cirrhosis. Due to the disease and the fibrosis of the liver, the portal vein comes under higher pressures due to this flow resistance it encounters. This is termed portal hypertension. This causes dilatation and increased flow to collaterals, and unfortunately, portal systemic shunting. This leads to varices, increasing gut bacteria translocation, and a portion of the blood bypassing the liver. This in turn leads to an inflammatory vasodilatory state brought on by pro-inflammatory cytokines and numerous vasodilatory substances, including nitric oxide. This causes first splenic, then peripheral vasodilatation, resulting in these borderline blood pressures. The heart compensates with an increase in heart rate, at least at first, and the patient's left in this functional hypovolemic state due to the vasodilatation. Unfortunately, this results in low effective arterial blood volume. This triggers the sympathetic nervous system and the RAS system to trigger regional vasoconstriction around the kidneys, putting the patient at risk for hepatorenal syndrome. There's also an increase in renal sodium retention, and this whole time, ascites is forming, worsening fluid shifts, deficits, and putting the patient at risk for spontaneous bacterial peritonitis. So what makes these patients decompensate? Anything from worsening liver injury, infections, and GI bleeds. And that results in this worsening hyperdynamic low SVR setting. But to make matters worse, liver patients aren't that easy. They also have a relative hypovolemia, and that's on a good day. Let's not mention if they have a GI bleed. They're also at high risk for sepsis. Adrenal insufficiency in these patients is not a rarity. And last but not least, they can also suffer a cirrhotic cardiomyopathy, and this seems to root from either a high output state or a stress-induced cardiomyopathy. So how do we treat these patients? Well, if they're in a decompensated state, we need to stop their diuretics and their non-selective beta blockers. We need to work up the cause of decompensation, and then we need to treat the underlying process. Then we need to move on to fluid resuscitation. And if the patient's at risk for AKI, most prefer 25% albumin initially. And there's a couple protocols that I'm familiar with. The one that I think's used most, at least in my area, is on day 1, the patient gets 1.5 grams per kilo of albumin to a max dose of 100 grams. And then on day 3, they get 1 gram per kilo of albumin for a max dose of 100 grams. From there, resuscitation is based on fluid responsiveness. We need to defend that MAP, that mean arterial pressure, and at bare minimum, this means norepinephrine. There should be a low threshold for antibiotics, especially in the setting of ascites and a GI bleed. And then lastly, renal replacement therapy if the patient's a transplant candidate. We also should consider TIPS in select patients. TIPS is transjugular, interhepatic, portal systemic shunt. And then lastly, in select patients, transplant. Now we're going to wrap things up with a quick talk on medications, and I just wanted to throw this slide in to show that distributive shock can come from practically anywhere, one area being medication-induced vasoplegia. In this example, we have lisinopril, an ACE inhibitor. In overdoses, we see vasodilatation, a low SVR state. This patient was admitted from the ER. They gave 2 liters of crystalloid and called you. You did a POCUS and saw hyperdynamic contractility with a normal left ventricular end diastolic area. This would signify a vasodilatory process. Given the history of ACE inhibitor overdose, you chose to utilize angiotensin II, or maybe your facility doesn't keep angiotensin II on formulary, and you reached for phenylephrine. You did this because myocardial contraction was intact. In fact, it was hyperdynamic, and this was a pure vasodilatory process. So to wrap things up here, distributive shock is generally a hyperdynamic vasodilatory state. And there's a multitude of causative processes seen here. From a diagnostic perspective, it's important that we get every shock patient into a shock classification and then focus on the etiology and treatment from there. That concludes our presentation on distributive shock. As always, I appreciate your attendance. You can post any questions or comments in the comment section at the bottom of this viewing screen right beneath the resource section. Until next time, take care.